Okay, there was a little bit of a glitch, but we were talking about Cushing's. So with Cushing's disease, you have high glucocorticoids. When you see that, you should think cortisol. So cortisol you can find in synthetic forms all the time, and we've talked briefly about cortisol before, but cortisol in your body, it's there as a stress response. It's there to bring up blood sugars, bring up blood fats, bring up blood amino acids. Basically, it's taking all of your energy forms and dumping them into your bloodstream. Why would it want to do that in stress situations? Because it's trying to push all that energy producing substance up into the brain to make energy, right? So it wants to get all the energy to the brain as fast as it can to get you out of a bad stressful response. And this was actually a really good response back in the day when we lived in caves and we'd have some kind of an animal like a giant bear that would come into our cave and we'd get out of that situation in a few minutes and then run for our life and then we'd be okay. Nowadays, stress responses to things like sitting at a computer or listening to your pathophysiology lectures and prepping for an exam or things like that. And it's not something that comes on and goes right away. It's something that lingers because as soon as you're done with this class, there's going to be another class that's even harder than this. And there's going to be another class that's harder than that. And there's going to be your career that depends on you remembering all the stuff from this classes. And the stress just stays around all the time. So high stress responsiveness makes you release lots of these glucocorticoids. Cushing's disease is when something broke where you're constantly releasing cortisol all the time. So it's hypercortisolism. Always high cortisol. So one of the things you're going to see is that you're going to have low glucose metabolism. You're not going to be using it. You're going to be dumping lots of sugar out into the blood. You're not going to store it up, in other words. Like insulin. Insulin stores sugar into your liver and your muscles. Cortisol makes you dump it out. It makes you pour it out into your bloodstream and raise those levels for an emergency. It's going to start breaking down your muscles. It's taking the amino acids out of the protein in your muscle and dumping them into your blood. It's going to take your fat storage, your normal fat storage, like on men, our fat storage is normally our love handles and a little bit of the glutes area. And with women, it's definitely around the thighs and the glutes. Well, those are the normal fat storage areas. Cortisol goes straight to those areas and starts dumping the fat into your blood. Breaks it down and dumps it in as free fatty acids. So now they're circulating all over the place. You've got high blood cholesterol, or blood fats. You've got high blood sugars, high blood amino acids, all out there for energy. Your body can only handle this for so long. Imagine if you kept dumping cortisol out, what's going to happen to your muscle mass? Well, your muscles are going to get skinny and scrawny. You're going to start breaking them down. So like your arms and legs, look at this woman's legs, look at her arms, they're scrawny looking. Your normal fat cells, so normally like on the back of her legs or the side of her legs, her thighs, are going to have fat, but not here. She stores the fat in weird places. She's storing it like on the back and between her shoulder blades. She's storing it straight out forward in her abdomen. That's not a normal place to store fat. Normally, we evenly distribute fat around, but here they're depositing large amounts right there in the front of their abdomen, right between their shoulder blades, and also in their face. You can see an example here, where she has kind of a slender face, and then after having Cushing's and all that cortisol, it makes her have what they call a moon face. So again, when you're looking at this pathway, it starts with the hypothalamus releasing CRH, pituitary releasing ACTH, going down to the adrenal cortex and dumping out cortisol. Well, when it dumps cortisol, ACTH also releases DHEA. So this is kind of an interesting characteristic. Is if you have a problem with this loop where you're releasing too much ACTH and it's stimulating the adrenal glands, you're going to release cortisol and you're going to release DHEA. So what's that going to do to a woman? Well, it's going to make her break down her fat stores. It's going to make her break down her protein stores. It's going to make her blood sugar look high like she's diabetic. But it's also going to make her have more masculine characteristics. It'll put more hair on her arms, more hair on her face. Maybe she'll start having to shave more regularly. It makes her skin real thin. It makes a man's skin the same way. Men will acquire these same things. You won't have a problem with hirsutism, which is hair growth. But a man in his abdomen, straight out. He'll have real skinny legs, real skinny arms, but his abdomen will poke way out. And a lot of times we giggle that off and say, oh, it's a beer belly. But actually, it could be Cushing's disease. You might see a lot of acne. You might see blood sugar and blood pressure problems because cortisol raises your blood pressure to try and push all that energy up to your brains. Probably the worst thing is that what it does to your immune system and your ability to heal. So cortisol, what it does, we talked about this before, it increases your neutrophil count. It turns down your eosinophils and basophils, which makes you more susceptible to allergens or parasites. But it makes the neutrophils so they don't go in the tissue. So when you do get a cut, or you get a bite, or you get a rip or a tear to your skin, it doesn't heal. You have a higher risk of infection. Another problem is what do you need to heal proteins like collagens in the skin? What's the raw material? amino acids. So Cushing's is breaking all your amino acids and dumping them in the blood, but not letting you use them to repair tissues. So another common characteristic you see is where they're gaining all this fat, you'll see striae. So here you have these little stretch marks because their abdomen's extending. And when you and I gain some fat, I mean, our abdomen starts extending, or our fat stores start stretching out. But as that tissue kind of pulls and tears a little bit, it heals right away, so you don't see the stretch marks. People with Cushing's disease, the cortisol prevents them from healing that tear very well, so it just keeps ripping and thinning and thinning and thinning. You see this reddened stretch mark area. So you'll see the same thing with blood vessels. When blood vessels get damaged or the pressure affects them and pops them, they don't heal very well. So you see purpura, you see petechia in their cheeks sometimes. But it has a lot of these effects. And because it's a stress hormone, it increases that stressful feeling. So it causes irregulating menstrual cycles. It causes problems with male dysfunction, sexual dysfunction, and everything. So I've been talking about Cushing's disease. And Cushing's disease is directly affecting this pathway that you probably have a pituitary tumor making too much ACTH, which causes you to make too much cortisol. Or you can have a tumor here in the adrenal cortex that makes you release too much cortisol. Here's the question, though. So have you ever heard of someone saying Cushing's syndrome, and then later they talk about Cushing's disease? So what I want you to do is look up the difference. There's a difference between Cushing's syndrome and Cushing's disease. And then the gonads. So the gonads, of course, in a woman, it's the ovaries. In a man, it's the testis. The primary purpose is to make a gamete and to make the sex hormone, so whichever sex you're talking about. So when you look at things like estrogens, if you have hypogonadism, it makes way too many estrogens. And a lot of times what it actually causes is sterility, because it causes this feedback loop to shut off your own production of estrogen. So what happens is you don't develop an egg, you don't develop that follicle in the ovary, because when the cycle turns on, if you have too many estrogens, let's say you have a tumor that's producing lots of estrogens, it goes all the way, I'll go over to the woman, it goes all the way up into the brain to the hypothalamus and tells the hypothalamus, whoa, too much estrogen, turn off gonadotropin releasing hormone. Well, then if you don't have that, you can't release FSH and LH, which means FSH and LH don't come down and start that ovulatory cycle. So sterility, same thing with hypergonadism. Hypergonadism is kind of interesting because it makes them look like they're going into puberty early. Same thing with men. If you give a boy testosterone too early, it can make them look like they're going into puberty early. But it's called precocious puberty, or pseudo-puberty is actually more common, because they're actually not sexually reproductive. They look like they're going through puberty because they start growing really fast, they start developing adult parts, they start, well, basically acting, their voice thickens in a male, the breast tissue expands in a female, they start growing axillary pubic hair because they have too much of the sex hormone. But the problem is that the timing. Puberty is based on time. There's something about the mechanisms in your body that are sensitive to time. When you start releasing these chemicals, your body's not ready to be reproductive, so you're not reproductive. So that's what they call precocious pseudopuberty. And then hypogonadism in man means that not enough testosterone, so even when he is actually ready to make sperm, he doesn't make enough sperm because his body doesn't make enough testosterone that helps it. So you can see the main purposes that happen with testosterone, what it does with us. Increases our sex drive and aggression. So if you have hypergonadism, what would happen to our sex drive and aggression? It would go up. With our skin, it produces lots of oils, sebum. So if you have hypergonadism or too much testosterone in your system, what would be a sign? You get lots of acne, maybe on your back, and your arms, and your face, all over the place. Makes our muscle mass bigger, and that's why people cause hypergonadism on themselves taking testosterone or anabolic steroids, because they act like testosterone, make your muscles bigger, increases our bone mass. So there are lots of purpose. It increases red blood cell production to increase oxygen, because for all this building and development. And the same thing with women. So too much estrogen may overdevelop the breasts. It may actually cause the bones to get real big and dense, which is a good thing. What happens at menopause? Well, at menopause, she drops her estrogen. So what's going to happen to her bones? Bones get weaker, more frail. Yep. The same thing with the heart. A lot of times we don't really talk about heart disease with women because we usually point the finger at the man, but in reality, heart disease for women, especially after menopause, goes up dramatically, because estrogen helps prevent plaques from building on the arteries in a woman. So it seems almost unfair that women have this protective mechanism. But when menopause hits, they don't have that protective mechanism anymore, so they get rapidly developing plaques. Here's an example, androgen insensitivity. So in this picture over here, you're probably thinking, oh my gosh, why did he put 4 naked women? It's not. These are all men. These are men that have androgen insensitivity. Androgen is the masculinizing hormone, and their body's not sensitive to testosterone. So back when I talked to you about problems, I said it could be the pathway's broken. I told you that it could be that the hormone's not being produced, so whatever the gland of interest is isn't working appropriately, or it could be the target cell. And in this situation, the target cells don't work. Because here's the situation. So it's an X-linked trait. Their karyotype has a normal 46 chromosomes. They're normal. They have an X and a Y, which means they're what sex? They're male. So you have the X and a Y, which means they are male underneath. But the situation is, if you have the Y, SRY chromosome, but your body's not sensitive to testosterone, you actually develop as a female. So they're missing the receptors for testosterone, and it makes them look female. They are a man. Everything about them is man. If you were to look inside their abdomen, they have testes inside. They don't have ovaries. They have what's called a blind, what do they call it? Short pouch blind vagina. So it indents a little bit to make it seem like there's a vagina, but there's actually no true vagina, and there's no uterus either. They don't have any of the real female reproductive equipment except they have breast tissue, right? They don't have fallopian tubes, they don't have ovaries, they don't have the uterus, right? They do have testes, and what looks like the labia are actually what would have been scrotal sacs, so scrotal skin for the testis to fall into, but they have the testis in their abdomen still. One of the key signs is at puberty, these girls, they're going through puberty, but they don't develop any pubic hair. So they don't develop pubic hair, they don't menstruate, so it kind of becomes a warning sign. But you can see they do develop breast tissue. So they're male, but they develop breast tissue, and basically when it's time for puberty, they don't get a lot of the signs of puberty. So at that point, they can actually give them testosterone, and testosterone may help them decrease their breast tissue and may help give them a little bit more characteristic, but that's only if they have some receptors for testosterone. If they have no receptors at all, no amount of testosterone that you give them is going to help them at all. So a lot of times what they have to do is they will actually do a gonadectomy where they go and they take out the testis, and then they can actually do a vaginoplasty where they can structure a real intact vagina. But of course they're never going to have children. All right, and this is where we went to stop, but we're going to go on with diabetes, the last section. So, of course, diabetes in the pancreas. We've talked about the pancreas before with exocrine. It excretes things in the GI tract, like alkaline fluid to neutralize stomach acids. It secretes enzymes to break down carbs, fats, and proteins. It has endocrine function, and that's where we're at now. So there are these little islets. If you take the pancreas and you slice across, you'll actually see these little areas in the middle called islets of Langerhans. And these islets have 4 special cells in them. They have alpha, beta, delta, and F cells. And the primary ones of interest are going to be the alpha and the beta. It's important to know what these chemicals are, though. Alpha cells secrete glucagon. Glucagon is insulin's mortal enemy, you might say. Insulin comes out because your blood sugar is high. Glucagon comes out because your blood sugar is low. Insulin pulls sugar out of your blood and stores it. Glucagon pulls it out of storage and dumps it into your blood. They work exactly the opposite of each other. They're trying to constantly oppose. So if they work like this with sugars, you could probably predict they're going to work very similarly with fats and carbs, or fats and proteins, right? So if your body's high in amino acids, insulin comes out and starts storing it into muscle. If your body's high in fats in your blood, insulin comes out and tries to store it into the adipose tissue. So if glucagon comes out, what's it trying to do to fats? It's trying to break down your fat cells, dump the fat into the blood, and bring your blood sugar back, or blood fats back up. If your amino acids are low, it breaks down your muscle, dumps the amino acids in the blood, and tries to bring your amino acid levels back up. Right? The beta cells, of course, are insulin. The delta cells are really something called somatostatin, which I'm sure you probably remember, especially if you had physiology with me, because I just beat it to death. What do you think somatostatin is going to do to alpha cells? What do you think it's going to do to beta cells? Its name tells you, body stopper. It stops them. Somatostatin is like this angry hormone that tries to stop everything. So when they give insulin, a lot of times they'll have something like somatostatin in it, so when they inject somebody with insulin, it has somatostatin to stop them from releasing their own insulin, so that they don't overdose on insulin that way. And then the last one, the F cells, are there for like mediating appetite. So they're called the pancreatic polypeptide cells, or sometimes they're called the PP cells. Right? But here you can see the loop between glucagon and insulin. As blood sugars rise, insulin comes out. As blood sugars start dropping back down, glucagon comes back out. And they're always in this teeter-totter trying to keep that balance. Their cells are neighbors. They live right next to each other. They have basically the same parent organ, the pancreas. I don't know why I said basically. They have exactly the same parent organ. So they're constantly competing. They're almost like a sibling rivalry where one does one thing and one has to do the other to compete. And I'm going to focus on the beta cells because this is where it's really significantly important in a clinical setting. Beta cells, you have to remember that they release what chemical? Insulin. What's the main thing that's driving insulin release in your body? High blood sugars. So those are a couple of keys. Insulin is regulated more than just by sugar. Insulin has chemical mediators, like I said, for blood sugars, blood amino acids, and fats. But it can actually be responsive to other hormones, like estrogens. So it's sensitive to things like estrogen. And then neuron connections, too. You can think about a sandwich. And that sandwich, your brain thinks about the sandwich, and it sends a signal from the brain all the way down to the pancreas and says, we're going to eat that sandwich. You better start releasing the insulin. So it can be chemical, hormonal, or neuronally affected. Here are the inhibitors. It's inhibited by low blood sugar. So this is a perfect negative feedback loop. High blood sugar starts it, low blood sugar shuts it off. Okay? Increased blood insulin concentration. In other words, if you have too much insulin, it shuts off your production of more insulin. That's a negative feedback loop. Right? And then sympathetic stimulation. Running for your life, you don't want to store sugar in your muscle in your liver. You want to keep it in your blood. So sympathetic stimulation blocks the effects of insulin. Right? Here's kind of a quick pathway. I went through this on another slide in the past. But so here's this cell, the beta cell in the pancreas. It's triggered by glucose. Glucose comes in, it binds or blocks potassium, and opens up calcium channels. So it depolarizes this cell. Well, that depolarized cell dumps out the insulin into the blood. Insulin travels downstream. It finds peripheral tissue like skeletal muscle or the liver. It finds that peripheral tissue. It binds here. It opens up a transporter for glucose, and it sucks glucose in and makes glycogen out of it. That's the long process. In diabetes, the two types of diabetes affect two different cells. Type 1 diabetes, which we're about to talk about, affects the beta cells primarily. They can't release the insulin. Type 2 diabetes affects primarily the peripheral cells, the target cells. These receptors are lacking or missing, or these enzymes on the inside are missing. Something's broken, so you can dump insulin out, but it's not as responsive. So let's go ahead and talk about that a little bit, because you're definitely going to have to deal with diabetes down the road. Right? So here's how insulin works, and I kind of jumped the gun and went through it already, but there's a biochemical signal, like high glucose levels, that turns on the beta cells. The beta cells release insulin. So insulin was this pre-packed hormone. It's a protein hormone, so you know it's water-loving. Does it work fast? Absolutely. If you took a big dose of insulin and inject it in your vein, you'd be dead within minutes. So it doesn't take very long to kill you. It works really quick. It pulls all the sugar out of your blood, and then your brain dies. Right? So where are we at? Oh, so you releases insulin, and then insulin goes up to the bones and makes you absorb amino acids and build bone. It also helps you build muscle. I was shooting for the muscle. It helps you absorb amino acids and helps you build muscle. It also builds collagen for bones too. So I wasn't very far off there when I said that. The other thing it does is it enhances tissue growth. So it'll help it store sugar. It helps it store fat. So if it's adipose tissue, it'll store the fat. If it's a liver cell, it'll store sugar. That way you have these energy forms later down the road. That's the whole purpose of insulin. Right? Most of the body is insulin sensitive, which means it responds to insulin, but the brain doesn't. Brain is not insulin sensitive. The brain doesn't care if insulin's there or not. All the brain cares about is the blood sugar. If insulin's affecting the rest of your body and pulling the sugar out of your blood, it's going to damage the brain or hurt the brain. But if there's no insulin in your body, your brain will keep pulling as much sugar as it possibly can and to stay alive. Right? Okay. And then this is kind of a quick pathway. I put this on here because I thought this was a really handy slide that I found online. And here you can see defects that happen to the beta cells. A defect in the actual beta cell itself, that would be a type 1 diabetes, typically. If it's happening to the target cell, it's type 2. But there are some type 2 diabetes where they just produce less insulin. So they decrease their insulin production. It's almost like their insulin cells can't keep up, their beta cells can't keep up with the production. But the primary problem you're going to see with type 2 diabetes is the receptors aren't working. With type 1 diabetes, it's that the beta cells aren't working. Right. And then you can just go through here and look at some of the potential targets that they're looking at. And then there's that pathway. So you eat carbs, the pancreas responds, releases insulin, it affects the glucose, the muscles, the fat, and then it stores all of those things, and finally reducing your blood sugar, blood glucose. So now diabetes. And you can look at diabetes. Diabetes is an epidemic. It's actually kind of a pandemic because all across the world, diabetes rates are going up. So the entire world's diet just pretty much kind of sucks in general compared to what it was 20 or 30 or 40 years ago when we had less processed foods. We didn't eat as much sugar as we did. I used to work for a Thai family. I actually delivered pizzas for a restaurant, and the whole family that worked there that owned it actually were Thai family. And anytime I would eat something, if I bring in like a cupcake or a cookie and offer them, they'd taste it like, oh, that's too sweet. It's way too sweet. We eat so much sugar in the United States, it's crazy. Okay, so diabetes, what it is it's a collective group of glucose intolerance disorders. Diabetes insipidus was revolving around ADH. Diabetes mellitus revolves around sugar, so don't forget that. It's the single most common endocrine disorder actually in the United States, and it's growing in I want to say popularity. It's becoming cool to have diabetes. Not quite, but it's growing in its prevalence and its incidence. Right? And then there are a lot of cases out there that go undiagnosed because people get the signs and they just ignore them and they just push it off to the side. It's the way we are in the United States, especially if you're male. You don't go to the doctor unless you're missing a limb. It's kind of the perspective I was taught as a little boy. Okay, so here are some of the common signs that you see, and these are a general overview, but historically the common signs of diabetes was weight loss, you urinated a lot, you were thirsty all the time, you were hungry all the time. You couldn't store sugar, so it increased your appetite. You wanted to keep eating. You were urinating a lot, losing all those sugars and losing the water with it, so you're constantly thirsty. And because you're pushing sugar out into the kidney and into the bladder, it's chasing the water with it. So you were urinating a lot. You're making lots of bladder that had this sugar in it. And then you still had weight loss because you couldn't store the sugars. You couldn't store the sugars, you can't convert them to fat, you can't convert them to anything else and store them. So here are the technical terms for urination, thirst, and hunger, and you can look at that and they'll be popping up again. One of the modern common signs, so something that's more of a new thing that we see, is this hyperglycemia that comes with it. And they find it's actually kind of a loop. If you don't have enough blood sugars, your liver starts responding and starts making more. So even when, or not enough blood sugars, when your liver doesn't have enough insulin, it'll start releasing more sugars. So let's say you have type 1 diabetes and you're not releasing insulin. Well, your liver's automatically going to start thinking, well, crap, we've got to raise the blood sugars. Well, if you just ate a cookie and you can't release insulin, and then your liver releases more sugar, you've got hyperglycemia instantly. Hyperglycemia is one of the right-away symptoms, like immediate symptoms that are associated with diabetes mellitus. More of the longer term, like if you didn't eat for 12 or 14 hours, then you see a hypoglycemia, or even 8 hours. So it's the longer drawn-out things when you see hypoglycemia. It's the right-away, a constant characteristic is hyperglycemia in these people that have diabetes. There are three major types, type 1, type 2, and gestational. So I'm sure you've all probably heard of those, but type 1, it's the beta cell. Type 2 is primarily, remember, I found the slide that shows this, or this picture that shows this, 95% of the time it's the target cell that's broken, right? And then gestational diabetes is, of course, while you're pregnant. So let's talk about type 1 first. Type 1 can be caused by lots of things. It could be congenital, it could be genetic, it can be a virus, it could be an infection, it could be blah, blah, blah. Something got in and triggered your body to attack your beta cells. So your body, it's an autoimmune primarily. Your body attacked the beta cells and destroyed it. So this is the older type of diabetes, the traditional old school diabetes that were written in ancient historical books, basically. And about 10% of the Western world actually has diabetes. Or, sorry, I shouldn't say 10% of the Western world. 10% of the cases of diabetes out there in the Western world are this type of diabetes, which means the bulk of them are going to be type 2, which is the one that can sometimes be controllable, but we just don't do it because we don't like to do it, right? So there's some genetic environmental reactions, there's therapeutic reactions, but altogether what's happening is that something has changed your beta cells or changed your body's want to destroy these beta cells, and it comes after it and destroys them. So it attacks them, destroys the beta cells, now you can't release insulin because the beta cells are gone, and then you have type 1 diabetes. We used to call this insulin-dependent diabetes because these people now, they depend on you giving artificial injections of insulin. We used to also call this child-onset diabetes because it was primarily a child disorder. However, now type 2 diabetes is kind of moving in there too, which was adult onset diabetes. So then type 2, I already talked about this. So this is non-insulin dependent diabetes mellitus, which is NIDDM. Right? It's way more common. So it's the bulk of the cases out there. It used to be more common to see this in people that were over 40 years of age, but now, thanks to fast food, convenient food, highly processed, sugar-filled foods, now we're seeing it a lot younger in life. People that are even in their 20s or earlier getting it. Right? There may be some genetic link because they actually find in twin studies that there's a link between people that get type 2 diabetes and these twins too. So we know that type 1 has some genetics. We actually know that type 2 has a lot of genetics involved in it too. If you have a family member that had diabetes, you're at higher risk for it also because of the genes. So let's talk about the pathogenesis. Right? So you normally eat a little bit of sugar. The sugar gets into your body. In your body, your pancreas releases insulin. Well, in type 2 diabetes, when it releases the insulin goes through the bloodstream, goes to the target cell and tells the target cell, suck in the glucose. The problem is the target cell is missing the right receptors. So the insulin comes along and can't activate the receptors, which means the sugar stays in your blood longer. Well, if the sugar stays in your blood longer, it can seep into the blood vessel walls. It can go to the kidneys. It can gunk up the kidneys. It can get into the kidneys and start pulling it into the urine and start pulling it out that way. So it goes anywhere but in the storage form. So if you have these sugar levels that are kind of high because you ate a sugary meal for a while, well, then you're okay. But when those sugar levels start dropping because all that sugar has been processed from your GI tract and taken out, now you have no backup sugar. Now you start feeling that kind of crash. Your liver will start making sugar out of amino acids, so proteins. They'll start breaking down your protein to make sugar. It'll start breaking down your fat to pull those fats out and turn them into sugar so that you have energy. The problem with both of those is they make a chemical called a ketone body. And these ketone bodies are really toxic. It's almost like sugar in your body is like burning wood in your fireplace. It's kind of I want to say green. I know it's probably not the perfect green thing to do is to burn logs in your fireplace. But anyway, it's a clean. It's more of a clean kind of energy, right? Quote unquote clean. This is why I'm saying clean, is because burning amino acids like proteins to turn them into sugar, that's like burning plastic in your fireplace. Sure, the plastic will catch on fire and it'll have a heck of a flame, but it's also going to produce all these toxins. Well, when your liver breaks down amino acids and uses them for sugar, it releases lots of toxins called ketone bodies. And I'm actually going to have you look them up, but they're very toxic to your body. Your brain can use a couple of those ketones for energy, but then it becomes really dangerous after a short time. Right? So non-insulin dependent diabetes, insulin resistance is in the target cells. They have a decreased number of those receptors. What could be happening is that the cells are actually just tired of it. They just don't, they're being abused for so long with this insulin. They're like, forget it, this insulin's killing us. And they stop popping the receptors up. Well, then suddenly you're not responding to insulin. Your blood sugar stays high. It could be that the beta cells are not responding appropriately. Maybe they're not making enough insulin. It's not like type 1 diabetes where they make no insulin. With type 2, maybe they decrease their production. Maybe you eat a sandwich and they just give you a little spurt of insulin, but not nearly enough. So maybe it's because there's not enough mass in the pancreas. Maybe it's pancreatitis that caused it. Maybe it's something else that caused it. There are a lot of options out there. Oh, and then the last one. Also, there's an abnormal amount of glucagon being secreted. When insulin's not working, glucagon will come out to try and balance it out. So in type 2 diabetes, you'll actually see a higher level of glucagon to try and balance this stuff out. So here's just kind of a note chart to compare type 1 and type 2. So you usually see age of onset with type 1 is usually under the age of 20. With type 2, it's usually over the age of 30. Always exceptions. When you look at type 1 and type 2, you can see type 1, they usually have normal weight. Type 2 is usually obesity, but diabetes did not cause the obesity. The obesity was actually like a precursor to it. So that's one of the unique features. They may be heavier set, but it's usually the obesity or the metabolic syndrome that they had that may have led to the obesity that caused this problem in the first place. Where you see in a situation lower blood insulin, over here they may have normal blood insulin. All right, so you can kind of look through and look at what's happening. I've already talked about these different things. And then just to come back at this again, most cases of type 2 diabetes were actually preventable. And I like this is kind of funny, so it wasn't really insulin. You don't have diabetes yet, but it was just a warning shot because you can obviously see with his head to his body ratio, he's very overweight. But the doctor's kind of a hypocrite too, so that's interesting. All right, So insulin is responsible for pulling glucose, lipids, amino acids from the blood and storing them. So the symptoms will be what when you have diabetes? Well, if insulin normally lowers your blood sugar, lowers your blood fat, and lowers your blood amino acids, and now insulin doesn't work, you're going to have higher blood sugar, higher blood fat, and higher blood amino acids. So these are like the key symptoms. You have hyperglycemia. You have hyperlipidemia. Now you have all those lipids in your blood, they're going to want to stick to the arteries, and they're going to start causing atherosclerosis. And then because you're breaking down amino acids and not building muscle, you have weight loss. So you're breaking all these storage sites down, and you're losing them. You're burning them up, and you're pushing them into urine and pushing them out of the body. You're going to lose weight, and it's not in a good way, right? So they have more glucose in the blood, and this increases the glucose filtering in the kidney. So now they're pushing lots of glucose into the kidney. That kidney now has this new solute in it. What's going to be attracted to a solute? The water solvent. Water goes in. Now you've got a lot of flow going through the kidney, which goes down into the bladder, which makes you urinate more. Polyuria, right? And then because you couldn't bring all the sugars back in, because those transporters that are pulling sugar, so you have transporters that are limited. They're running all the time, but they can only pull a certain number of pieces of sugar out per minute. If you exceed the number of pieces of sugar, then that sugar that you couldn't pull out goes right down to the urine. You excrete it out, right? And that's because you exceeded what they call transport maximum, the maximum number of pieces of sugar you can transport in a minute, right? So as a result, you have diuresis, and it's osmotic diuresis because it's a lot of solute and a lot of solvent that are going at the same time. And then, of course, polyuria, polydipsia because you're thirsty, right? You're urinating a lot, you're losing a lot of water, you're feeling dehydrated, and polyphagia because you're losing lots of nutrients. And over here you can see, I thought this was kind of a handy little picture. That's some of the signs of diabetes or symptoms. Right? Some of the delayed, and delayed means like not right after meals, not immediately or right away, but potentially 12, 13, 14, 20 hours later. Then you start seeing hypoglycemia. So this is more of an acute response. It's a little bit drawn out. But you have this rapid decrease in plasma glucose. After you've used up all of the sugar you can possibly use, after you've used up as many amino acids as your body's comfortable using, after you've used up as many fats as your body's comfortable using, now your blood sugars are going to plummet, right? And then one of the big causes of this is actually, taking too much insulin. If somebody overdoses on their insulin or they don't take the right type of insulin, they can actually get insulin shock, where now all of their blood sugar has been pulled out. So it's long and delayed, or it's because their insulin is not appropriate. So here you can see the neurogenic responses. If your brain doesn't get the sugar, what's it going to start doing? It's going to start shutting down. It turns down. But what your brain's going to start thinking is, we just need to get more oxygen, more sugar to it. So what's going to tell your heart to do? It's going to say, pump faster, pump harder, right? So they're going to start pumping their heart harder. They're going to push all this blood into their head, and it's going to increase their intracranial pressure. They start getting headaches. They get a little dizzy, a little confused. They might start having visual changes because the neurons aren't firing appropriately at the right speed. So they start getting sleepy, and they just want to crash. If you see somebody that's going through hypoglycemia, like a diabetic that's going through hypoglycemia, they look drunk, right? Their level of consciousness is decreased. They're sleepy, tired. In severe situations, they can go into a coma and die. Another problem that's delayed is when this is happening and you're burning all those lipids and amino acids for energy, you get something called ketoacidosis. Ketone bodies accumulate when you're making lipid and fat, or lipid and amino acids and sugars. Right? So ketoacidosis, you can see your body will take all these different things, amino acids and fatty acids, bring them to the liver, and the liver will take the amino acids and fatty acids go through something called gluconeogenesis, which means creation of new sugars, right? There's very little glycogenolysis. Glycogenolysis means that you have sugar stored in the liver in glycogen form, and then you lyse it. You break it apart, and you release the sugar into the blood. You don't get a lot of this because you didn't store a lot of sugars in the first place. So when you go through gluconeogenesis, you make this ketone body. The ketones go into the blood, and they're acidic. So they actually drop your pH. They make your body more acidic. Do you remember what kind of acidosis that would be? If you don't, make sure you look it up. Right? So it's something where your body is making these acids unrelated to the lungs, and it's making your body acidic. One of those chemicals that it makes, one of the types of ketone body, is acetone. And I know you've heard of it because if you've ever seen fingernail polish remover, or even if you're a guy and the fingernail polish remover sitting on the counter, You've probably seen acetone there on the label, but this acetone, when it's converted and it goes into the GI tract or into the lungs, when they breathe it out or exhale it out, it converts to a kind of like a juicy fruit smelling. I don't even know a better description, but it's kind of like almost fruity in its smell. So your homework is, what are the symptoms of ketone acidosis? And I kind of answered some of them, but what would be some symptoms as far as the breathing goes? Like, not just what it smells like, but what about their breathing rate? What about their levels of consciousness? What might you expect? What might be happening with the kidneys? And then tell me any other significant effects that you find. So go ahead and you can look that up online and write it down. Right. Chronic complications of diabetes, so long-term changes. These are really significant because diabetes is a chronic disorder, right? So if you don't maintain it, you don't take care of it, all of these complications start building up faster. And you can see some of these like a dead foot, right? Circulation gets decreased to the foot, it starts dying, it starts getting infected, it starts becoming gangrene, and then you lose the foot. Having peripheral neuropathies, where you're just getting decreased blood flow to the hands and the feet. Having cardiovascular problems, vision problems. You can see lots of these, and actually we're going to go through them in the next couple slides. But these are really significant problems of people that don't keep their diabetes under control. And I know you've heard of people having to lose feet because they weren't controlling their diabetes. So let's talk first about the macrovascular disease. Macro means the big vessels. So, of course, we're going to go back to the atherosclerotic plaques. We talked about this when we talked about cardiovascular. The way I think of it, I remember, is if you have too much sugar floating through your blood, you got lots of this sugar floating through here, that sugar is going to start eroding and sticking to the walls of the blood vessels. Do you want anything sticking to those blood vessels? No. When the sugar starts getting to it, that sugar is going to start causing an inflammatory response, right? So with the inflammatory response, you might have thrombin being activated, which causes blood clotting. You'll start having plaques that start forming along here. You might have formed an actual thrombus on here. But it's going to damage those walls. You have that inflammatory response, which leads to atherosclerotic plaques, right? So it increases the risk for things like coronary artery disease, heart attack that we talked about last week, congestive heart failure, stroke, peripheral vascular diseases like in the foot and the hands, and of course increase the risk of infections. And here you can see kind of the progression. So you have that reduced blood flow. It might be pain, achy, while the neurons are still there. Calluses start forming, then you start getting the numb and tinglies, and that kind of like that when your leg falls asleep sensation where it's a shooting pain, like that. Then when you're not getting good blood flow, you kill the neurons, and at that point, it's kind of it becomes painless. And then you can stub your toe, you can do some damage, you can get some ulcers because you're not getting good blood flow. You get an infection in there, you get gangrene, and then you lose the foot. Another problem with decreased flow is that as the flow is coming around, you get some high pressure flowing through the arteries, but then you get the vascular backup, right? So the venous backup. So you get some swelling. And here you can see swelling in the early stages, and then in the late stages kind of bulging out, right? Diabetic neuropathies, I kind of already talked about this, but you can see the decreased blood flow coming through here as it gets getting thinner and thinner because of like plaques, atherosclerotic plaques, or just bad blood pressure that's happening. Then these neurons start dying. Well, when the neurons start dying, you get no signals going through them. You get no repair. You get no warning that there's damage. And then you can see when this area needs blood flow, there's nothing sending signals up to the brain saying, hey, increase the blood flow down there to the feet. So circulation gets poor, damages, dies. See the last slide for the outcomes. Right? Even with the diabetic neuropathies, it doesn't have to be the foot. It can be other things like the GI situation. So if you're decreasing motility through the GI tract, you get more constipation, you get malabsorption, you get problems with movement. So even with extra sugars in your diet that maybe you're not able to absorb, that goes down to the large intestine and causes bloating because all that bacteria start processing it. But you can see kind of the progression that we've already talked about. And here are some symptoms. I don't know if anybody remembers Wilford Brimley, but I remember him as the Quaker Oats guy when I was a kid, and then he became the diabetes spokesperson. But man, he's fighting for a really good cause, because here are just some simple ulcers up here in the top corner. And here you can see where people have had 2 of their toes amputated and they still have problems going on. Here's an infection that got way out of control. Right, time to get the antibiotics out on that one. And then here you see some gangrene. They totally lost that toe completely. I couldn't even imagine just breaking a toe off like that. And then you can see the gangrene. So hopefully this drives you to put down the candy bar and pick up the bowl of oatmeal, right? And then macro is the big blood vessels, microvascular are the little tiny ones. And the primary areas you have to worry about here are the eyes and the kidneys. So in the eyes, you've got all these tiny sensitive blood vessels. If they start getting clogged up or blocked up, I mean, you're not going to get any blood flow around the eye. What's going to happen to this tissue on the side, all this peripheral tissue around the side? It's going to start dying. Remember in the nervous system we were talking about having floaters, right? So you have this tissue that's dying, and little pieces of it, the cells are dying and falling off into the vitreous humor, and they're just floating around in there, right? So that causes things like retinopathy. It destroys the retina. And here's just the progression. So you get that thickened blood vessel wall, decreases blood flow to the eye. Now the capillaries aren't going to work, right? The capillaries are going to start blocking off. What's interesting is sometimes you can see the new capillaries forming in different directions trying to work around it, but they're not always that effective. And that's called angiogenesis, if you remember. We talked about that in cancer. And then you have decreased perfusion to the tissue, ischemia, death of the tissue, and then it starts peeling off like I was talking about. And of course the vision is going to be lost through this area that isn't working anymore. Right? The retina is extremely metabolically active. You start shutting that off, your vision is going to go away right away. You can have these little things called microaneurysms, so you can see it's kind of a bulge there, and then if they rupture, man, that's bad news. Because downstream, no blood flow is going to go. I think I covered everything on there. Yeah. And then the kidneys, same idea, the little tiny glomerulus. We talked about this when we talked about kidneys before. So we talked about glomerulonephritis. Now we're talking about something called glomerulosclerosis, which means scar tissue on the glomerulus. And here it's called focal segmental glomerulosclerosis, or FSGS, you can see here in the abbreviation. And what happens is when you damage these blood vessels, they're blood vessels, right? They get atherosclerotic plaques, the blood pressure, like hypertension, can actually cause damage. You can start getting some blow through, some damage, and when they start healing, they just scar over, right? So they're never going to work the same. And some of the symptoms you'll get, blood seeping through, protein seeping through, like albumin. Of course, when these cells aren't working, they're going to produce erythropoietin, so you're not going to have effective production of red blood cells. So this is just another outcome of diabetes. And you see diabetes is covering lots of things. Nervous system, cardiovascular, vision, the kidneys, all over the place. They might start getting more foamy like urine because of the albumin that's in it. I always think it makes it kind of like a meringue, right? Because a meringue is made out of the whites of eggs and you fluff them up. Never mind. It just helps me remember sometimes. But anyway, so you want to remember those things. Hypertension just exacerbates this. And what really sucks is that when you're damaging this, you damage the renin-angiotensin-aldosterone system, which causes hypertension too. So when you start screwing with that renin, it causes hypertension that comes back around and starts damaging the kidney even more. So there's another outcome of diabetes that's not controlled. And then the last thing here, gestational diabetes, and you can see about 2 to 10% of pregnancies have it. It's actually still on the rise, it's increasing. About 5 to 10% of moms have type 2 diabetes postpartum. So, and then about 35 to 60% of moms that had gestational diabetes will have type 2 diabetes within 10 to 20 years. So there are a lot of studies out there, and that's why the flux is so big between 35 and 60%, but it's a big problem, right? And what's happening is that they're making too much of certain hormones, and one of the hormones that they make too much of is something called somatomammotrophine. It's right here somewhere on the slide. Yeah, there we go. So the placenta is making something called somatomammotrophine. What this does is it goes into mom's blood and it makes her tissues insensitive to insulin. So it makes her tissues insulin resistant, which is actually how we describe type 2 diabetes. So she basically has this type 2 diabetes going on because the placenta is making too much of these hormones. So here you can see the example. The placenta makes the hormone, it goes out and makes her either pancreas turn down its insulin or it makes her body insulin resistant. Right? So think about what would happen to the baby. All that sugar going into the baby. What could happen? What could possibly happen? Right? I want you to think about it. But I'm just going to let you know it increases the risk of things like cesarean section. The baby's going to be, well, I'll let you look it up. But there are a lot of risks that come to mom and baby. And that's actually the last homework question, so I don't want to give away too much. But this is really important because it increases the risk of mortality for mom and for child. And it's shown that the last study I found was in 2008 that the rate of diabetes has actually doubled over that number in the prior 6 years. Right. Homework number 8. What are the risks of the mother in gestational diabetes and what are the risks of the baby in gestational diabetes? And I put a couple cartoons in here to see us out, so you can just pause if you want to read them, and they're kind of funny. And I'll see you with reproductive.